I was going to say that whoever came up with this topic was very smart, because it's a more complicated question than you think. So what actually is the question, right? Does anyone care about prone versus lateral? So when you ask that question, what you're effectively saying is that, is there a difference between prone lateral and lateral decubitus? And if there's a difference, is one better than the other, right? So what is better, if there is something that's better? Does better depend on the goals that you have, that you want to achieve with respect to your correction? And what's practically better in your hands compared to the literature or world expert like, Dr. Pimenta, Dr. Uribe? So let's go back to basics. This is always worth repeating. Lateral lumbar interbody fusion has incredible advantages. No need to repeat them here. You're all aware of them. There's obviously both coronal and sagittal benefits with respect to placing a large cage in the lateral space and having the option of dividing the ALL to achieve the correction that you want to achieve. But it comes with a price. And the price is that there's neuropraxia involved, obviously, to the plexus. Is the sagittal correction enough without some kind of posterior column osteotomy? It can't treat L5-S1, although wait for the punchline later in our discussion. And positioning takes time. There's the hassle of neuromonitoring. And then traditionally, we're repositioning these patients to achieve our additional correction for either posterior fixation, osteotomy, or direct decompression that we need. So you can see that all of this is leading to a point here. So then we came across this concept of single position surgery, or single position lateral surgery. So it was the lateral interbody followed by posterior instrumentation in a single position. Typically by that, we meant that we kept the patient in the lateral decubitus position, and then we performed both insertion of the large interbody cage into the disc space, as well as achieving our posterior instrumentation. But the problem is that there's still difficulty. There's difficulty with direct decompression. Those posterior alignment techniques can't easily be done. The inferior screw, we kind of demonstrated it yesterday, is still challenging without some kind of cheating technology to help you. And the other problem is it's resource intensive. There's sterility issues, there's optimizing a surgical tech placement, and there's bed rotation.
And I want to point out something very important. Front and center of the picture, the sign of a spine artist, the nylon mallet, the artist's mallet, not some crude metal hammer, a mallet.
Fantastic.
Nice. I love seeing that.
There you go, Dr. Chapman. It was there in honor of your point. So that then leads to the evolution. Everything evolves in life, right? So in 2020, came across this incredible surge of activity centered around essentially the same technique. And I know Dr. Pimenta will challenge me on this, that these are not the same. But I ask for his indulgence with respect to just broadly putting them into the same category while being respectful of the differences. So thank you very much, Dr. Pimenta, because you're the expert here. So essentially, if you give us license to put them in the same category, what all of these things are is a lateral technique, but in the prone position, okay? And that includes both your transpsoas work, it includes thoracolumbar approaches above the psoas muscle, and of course, it still includes anterior to psoas work as well. And so, back to the original question, why do we care? Well, where is it different? How is it different? So there's a few things that I want to talk about. Number one, and probably the most important point to bring out, and one where there's most evidence, is lordosis, is the value of lordosis. Then it's the perioperative factors involved in performing this procedure, prone versus decubitus. Then the big one, which is indications. When would you consider one versus the other? Then are there technological advancements or considerations that come into play? And then what's your algorithm for finally deciding what operative intervention you're going to place? All right, let's start with this one. So why do we care? Here, obviously, you just heard it in multiple talks in this seminar, in this symposium. Basically, improved lordosis means better mismatch between LL and PI, which we know leads to improved patient-reported outcomes. So prone theoretically increases lordosis due to the following. When you're positioning a patient prone, there is hip and thigh extension. That means that there is a logical change in the disc angle. Then, when you place the interbody, maybe because of technique, you're more likely to place the interbody anteriorly. And again, that depends on where you are in the steep learning curve. But there is a tendency, at least initially, to have gravity impact where you place a cage, and it's going to be more anterior. And now we have specialized patient positioners and bolsters which allow further extension of the hip and thigh to achieve improved lordosis. So you can see where I'm going with this. This is like a major advantage of this technique. So what's the evidence? Well, we have Dr. Pimenta and his team to thank. First up, they were the first out of the gate with respect to the data on this. So they demonstrated that there was improvement in segmental lordosis, approximately more than 6 degrees of lordosis. It didn't tend to be global, but it was segmental. And that in their study, only 12 out of the 22 patients that they had where there was a mismatch of 10 degrees or more had a mismatch of 10 degrees at postoperatively. So there was a significant impact on lordosis. This was followed up by Dr. Uribe and his team, which demonstrated that there was, again, same message. There's improvement in segmental lordosis, not global lordosis, lumbar lordosis. But they demonstrated that there wasn't a significant correlation between where you place the cage and the lordosis. In other words, it didn't explain fully the lordosis, which is an important contribution because it's not just because of the cage. In other words, it has to be to some extent from the positioning. And then this year, in Polina's study out of Buffalo, they performed propensity score matching in 10 patients where they matched these patients for lateral decubitus and prone. And again, they demonstrated that there was significant improvement in segmental lordosis and not global. And that, of course, led to improvement in LLPI mismatch, and they found some clinical factors as well. So where are we going with this? It then led to this systematic review, which I was very pleased to see, and it's very helpful. So this group out of USC actually performed 2 meta-analyses in their study. One was they compared the single position surgery versus the dual, so in other words, a flip. And then lateral single position surgery versus prone. And they had 17 studies in the second category, which is what we're focusing on today. 13 in the lateral single position group, 4 in the prone single position group. So 785 patients, 85 in the second group. A little bit of a mismatch. Obviously, there's much more literature to date with the single lateral decubitus position surgery versus prone. But basically, this is the punchline, right? And the punchline is that with prone, you are going to get an improvement in segmental lordosis. There is obviously improved accuracy of screw placement. That's not, it's believable, it's plausible because of the natural positioning of the patients in the prone position versus lateral decubitus for instrumentation. However, they found increased radiation exposure, some leg numbness and pain, and operative time and blood loss. And why is that? Well, again, it's logical because it's the fact that this is a relatively new technique. Most folks, most surgeons that begin this technique are somewhere earlier on in the steep learning curve. And so the duration of the approach, the amount of time of retraction, the degree of retractor opening has an impact on the plexus. and of course injury to the plexus. So this is natural. So most of us start towards the left of the steep learning curve, and hopefully at some point there's a rapid improvement with respect to technique before we become proficient and ultimately, hopefully, a master. But regardless of where you are in the learning curve, there's still improvement with lordosis and better placement of the instrumentation. So this was a very important point to make. So then let's divide and dissect the technique a little bit better. So why would you do it? Why would you consider it? One is that it's familiar positioning for most spine surgeons and for most spine procedures. The patient's lateral, we position most of our traditional open posterior approaches are done on an open table, such as a Jackson table. This is a familiar position for us. Secondly, we're able to do the necessary posterior work that we want to do without the necessity for the flip, because a flip means increased time in the operating room, sterility issues, it's labor intensive, we waste resources, we have to reobtain bovies and suction tubing, and things are thrown off the field. So in other words, there is naturally significant improvement with the fact that you don't need to flip a patient. You can achieve your fixation instrumentation through both open and MIS techniques easily compared to lateral decubitus. You can perform direct decompression easily compared to lateral decubitus. You can perform your osteotomies if you need to achieve further lordosis easier through prone position. And of course, you can then tackle L5-S1 if you need to by putting a TLIF or PLIF at the lumbosacral junction. Again, we're coming to that later in the talk. So, and of course, we can achieve increased lordosis, as we just discussed, by positioning the patient prone. So for all of these reasons, there are significant benefits to considering prone. So in other words, it gives you all of the advantages of lateral, which is the increased surface area for the arthrodesis, the segmental height and angle restoration, and the possibility of using expandable cages, performing ALL release and anterior column reconstruction, plus all the necessary prone steps. It's a great advantage for achieving your goals. So let's look at a case and consider it. So we got a 69-year-old male. He's had a progressive low back pain following L4-5 decompression and fusion several years ago, symptoms consistent with neurogenic claudication. Like a few other patients we've discussed today, previously had a spinal cord stimulated placed. That was then removed, and here we are. So you can see, for example, if you look closely, that there is pseudoarthrosis at that L4-5 level that was attempted to be fused, both because on the imaging there's lack of any bony bridging density seen on the x-rays, but also if you look carefully, you're going to see disruption of the L5 screws with the presence of a fracture, as is better demonstrated on the CT scan here. And in addition, there's spinal canal stenosis worse at L1-2 and less so at L2-3. So in this situation, you have multiple goals that you need to achieve. So what are the goals? So they were adequately treat the pseudoarthrosis at 4-5. You need to, in our case, we decided that revising the interbody cage was going to be the way that we were going to do it. Achieve a direct decompression from L1 to 3 due to the severe spinal canal stenosis leading to the symptoms of neurogenic claudication. Achieve disc height distraction, or at least preserve disc height distraction and segmental lordosis, and improve it with a cage at 1-2, and preserve the lordosis from L1 to 5. So these were, I tell my residents, it's important to be clear with what your goals are going into a case, because then you can craft your surgical strategy around what you need to do. So what do? So we positioned the patient prone, we marked the patient, we performed a approach in the prone position to the lateral lumbar spine. We placed our retractors, And initially, we performed a lateral lumbar fusion at L1-2 by placing a big cage with a increased footprint. And then we tackled L4-5. We removed the TLIF graft at L4-5. This is it there, which we achieved through the lateral approach, through the prone approach, lateral in prone approach. And then we inserted our big cage at 4-5. And then we had the ability to revise the instrumentation, which had failed due to the pseudoarthrosis. And so we removed the cage, we replaced it with a bigger cage at 4-5, we placed a lateral cage at 1-2, and we decompressed and fixed, and we did it all in the prone position, and this was the final outcome. So the question then becomes more interesting, because if you're beginning to buy the advantages of performing prone single position surgery, then let's flip the question and say, well, when wouldn't you do it? Okay, when would you consider not doing it? So for instrumentation placement, we know that there's significant advantages with keeping the patient in the prone position. Direct decompression, there's significant advantages. Lordosis, we demonstrated significant advantages. Patient obesity, this is an important factor. Often there is rolling over of the flank of subcutaneous fatty tissue, and as a result, the retractor blade lengths that are required to achieve access to that part of the lumbar spine need to be increased. So that's a consideration, but it's a relative one. Adjacent segment disease, where you decide to fix with a plate only, maybe. Thoracic discectomy, maybe. Revision surgery. Initially, I was questioning whether, would it really work when you wanted to place a lateral interbody or not, and any other surgical indication. And now this is our progression, even in adjacent segment disease, where we decide to place plate fixation, and I do that very rarely because of coronal fractures and so on. I still prefer to position them prone because it gives me an option for posterior revision or posterior placement of instrumentation if I need to. In thoracic corpectomy, that can be done prone. Perhaps the only indication for me, the definitive indication, is a thoracic discectomy, such as through a retropleural approach, or a tumor in the psoas muscle, such as the schwannoma, that we can approach that way as well. But this isn't the end of the story. If you thought that I'd convinced you about prone, there is one complicating factor, and that is about L5-S1. Currently, the TLIF-PLIF is the only option in the prone single position lateral versus a lateral ALIF done during lateral decubitus single position surgery. In other words, if you're going to position the patient prone, at the moment, you're tackling 5-1 from the back, okay? And if you are a big believer, as I've had you believe, that a large cage with a big footprint is the way to go for achieving all of the goals of correcting your global, or at least your segmental lordosis, and achieving arthrodesis, then you can question me and say, well, a TLIF cage is only going to give you a small footprint. So where's the consistency with that? Particularly because at 5-1, as you heard Dr. Sanser and others say, the majority of your lordosis comes from 5-1 and then 4-5, and much less from the rest of the lumbar spine. So you want to preserve it, if not improve it. So if that's the case, then the contribution of a lateral ALIF is a serious consideration, and hence single position lateral decubus surgery is a serious consideration for this alone. And there's data now available where there are algorithms built for consideration of L5-S1 and placement of a lateral ALIF, particularly when 5-1 needs a solid arthrodesis, when we don't need to achieve an indirect decompression, and no significant osteotomies are needed as well. I should say direct decompression. And you don't need a significant osteotomy from the back. So in other words, is a flying car possible? We talked about this yesterday. Is Dr. Uribe here?
Yes.
Excellent. So Dr. Uribe, I think this is a good picture, and I can see you flying this car in the future, with this is a Lamborghini, so I know as a car enthusiast you appreciate this, right? And hopefully this is you in the future flying the car. But basically, the question was, is it possible? And there's some data that says it's possible. And then if we want to get really fancy and talk about other considerations, what about the concept of bringing technology? Well, we just talked about screw accuracy, we talked about efficiency, we talked about increased radiation, and you can effectively challenge and tackle some of these topics by doing or considering robotics, such as screw accuracy, radiation, and considering preoperative planning for placement of your instrumentation as part of this single position technique. And like anything, there's the disadvantage, and that's the steep learning curve. So in our case, to finish off our series of prone cases, 65 patients up to now. We're actually a little bit more than that right now. Most of our cases are of course, still through the left side, and a variety of different posterior fixation techniques from MIS to open. The vast majority are the single levels that we treat. We like the expandable cages, and we apply the indications across a range of different deformity and degenerative indications. And of course, we're not immune to the complications. We're not immune to the complications of lateral. So I think, prone single position surgery is becoming established. There's a lot of data from both Dr. Pimenta and Dr. Uribe and other groups that have demonstrated not only feasibility, but also advantage to it. And the conclusion is, does anyone care? Okay, so success depends on your commitment to the learning curve. Okay, we demonstrated that. Where are you? How effective are you to minimize the complications involved here? We talked about the indications and the yield in terms of increasing your indications for different goals that you can achieve. Technology will continue to play a role in continued development. L5S1 is a serious factor for reconsideration. So in other words, don't throw out lateral decubitus single position surgery yet. So the answer is yes, you should care, but always do what's best in your hands, in your institution, in your situation, for your particular patient. All right, thank you.
Very nicely done, very balanced. I have a question of something I've seen more and more often now. Whether it is PTP or lateral decubitus combined anterior column posterior surgeries, Rod and I have seen more and more patients where a surgeon has done cages anteriorly very nicely, and then in a multi-level construct fired unilateral screws. I assume in part, maybe because of the usual problem of the dependent side in a lateral position patient to get the downsided screws into a proper trajectory. They always kind of are windshield wipered off, even if you're very careful. So what are your thoughts? What's your advice to this group in terms of this maybe new, maybe incidental, hopefully not common phenomenon of having multi-level unilateral rods for these patients where there's a nice anterior column construct? Yeah,
I mean, we see it. We've seen it not even just with anterior, but with posterior fixation with the T-lift as well. I think, a lot of it came from initial data that showed that unilateral fixation was non-inferior. There were studies early on that showed there was non-inferiority with respect to the metrics of arthrodesis and preserving the lordosis for the end of the follow-up time period in those studies that they had, which was inadequate. So to your point, what we've seen is that obviously nothing beats stability through increased fixation, such as bipedicular fixation. My suggestion to the group is learn how to do, if you're going to choose lateral decubitus surgery, if that's going to be your standard of doing single position surgery, do not give up on the inferior screws. You can achieve it. Careful positioning of the patient, not too posterior, where it becomes difficult, for example, to do an anterior to psoas approach and not too anterior, where collision of your hand and the driver with the bed becomes an issue, is a consideration. But I challenge you to do it prone, where it's not even an issue anymore, where placement of the instrumentation is not any more of an issue than any traditional prone approach.
Let me ask first Juan and then Luis for commentary. So Juan, the question was, we're seeing more and more unilateral multi-level screw fixations with cages. I think Rod and I have exchanged several patients. Is this reasonable, or is this just kind of absconding responsibility on the part of the surgeon?
The short answer to me is no, because I'm going to take this one as an answer to you. Can you drive a car with one hand? The answer is yes. So why most of the people drive with two hands, So the point is that we know that the best biomechanical construct that we create is bilateral pedicle screws, is that biomechanically the most stable. You get to the 3 columns, is the most sounding construct. To me, is when you go unilateral pedicle screws, especially in single position lateral, basically you're showing that you have a lot of difficulty putting the screws on the low side. Because if you come to me and you say, I'm using unilateral pedicle screws, but I'm doing it on the low side, then I get it. You have a reason maybe. But if you're just doing it because you're putting it only on the easy side, it means you're telling me that you have a severe technical limitation that doesn't let you do. And then when you go and do the case in prone position, open or whatever, and you put bilateral rods, I say, why you not keep doing your unilateral rods? You're just saying that it's very good at that. So my answer is, when I see that construct, it's a limitation of the technical ability, because of the position or the technology, you name it, to do it. I mean, Nuz is showing a really good examples how he can get the lower screw with the robot in a really good, doing a really good job. My biggest challenge with single position lateral is that definitely treat deformities is almost impossible, Passing a rod T10 to iliac on lateral, I mean, that's a really daunting thing, and that's something that we are not going to see with the prone lateral. Obviously, the prone lateral has its own challenges, the access of the thoracolumbar junction is a little more complicated than on lateral position, because the ability to really move the ribs away is a little more, but that's all technical thing that as the bed positioners get better, and as we become more facile with that position, I think it will come naturally. I put, for example, if this one was, if we were in the casino betting, I will put more money on the prone lateral single position than on the lateral single position. Definitely, I put more of my bets on that side. I don't know, I mean, Dr. Pimenta, I know that you're pushing a lot for prone lateral, but that's the way that I see it. I don't know, Rod also that is doing, Rod, you're doing prone laterals also,
as everybody knows. And the answer to unilateral screw is the same answer to lateral plus plate. It's no better biomechanical solution. So that is clear result of making what is easier, not what is better. This is not the biggest discussion. Very good presentation, excellent, love it. You only missed one point. And the difference in between doing prone lateral versus doing PTP is not the retractor, it's not the company itself, is building a procedure directed to that new position. And how we can make corrections on the problems we had during the 20 years of lateral procedures in lateral, and could have done in posterior as well. But one of the 3 points that the prone lateral, the PTP procedure has advantages on what you showed is the neuromonitoring. Because the reason that we have more neurological problems first is because the level that is frequently more in role is L4-5, where the plexus is there, and we have to learn how to avoid to damage the nerve. It's not only finding where the nerve is, which is EMG, but during the procedure, what we can do to prevent the nerve to have ischemic compromises. At the end, you had a beautiful position, but you have a neurological problem. And this is SSCPs. So if you don't have SSCPs monitoring in L4-5, you are exposed to more risks during the procedure. And the reason is that the previous studies that we published on the time spending inside the psoas muscle, saying, oh, you have to do under 20 minutes. Right now, by what we are learning now with SSCPs, the compromise on the nerve can happen on 5 minutes. And you can see the wave coming down at 5 minutes that oblige the surgeon to close the retractor, wait, and reopen the retractor. And this is, as in deformity, the best way to preserve neurological complications.
But would you, to that point, would you say a lot of it is technique and, for example, it's degree of retractor opening? So rather than time, I mean, we always said time, right? Now, are we not learning that it's the technique of the surgeon, it's the amount of retractor that's open? If you go crazy and you open the retractor wide, you're going to obviously...
You remember that in early times, we would come close to the plexus and open to the front as much as possible. We want to see a good amount of disc, etc. Right now, we just open enough for the size of the cage that we want to implant. This is one thing. So there are different nuances on the technique that we have to follow. It's not the easiest procedure, but nothing is easy in life, right? You have to learn every step.
Yeah.
Nuj, that was an excellent talk. I mean, I think for me, this is a fascinating area, having, been doing lateral surgery for about 15 years. I think the most important thing for me is, people focus on the lordosis, but I think the plexus for me is still one of the areas. And what's fascinating to me is again, when I first started doing lateral surgery, and I learned this from Dr. Pimenta, I actually used a microscope. I would go down, I mean, this is in the early days. I would find the plexus. Okay, I had no idea. And, when I looked at all these textbooks, everything is written about the brachial plexus. There's not anything written about the lumbar plexus. And all the cartoons and illustrations are all wrong. You go in.
It's the LA freeway, right? Remember?
Yeah, and it took me about 15 years. We finally published a book on this, and it's just on the anatomy of the lumbar plexus. But I would go down, find the femoral nerve, and actually dock, as Dr. Pimenta said, dock right on it, because I was so terrified that I would cut it. And I remember as a resident, we did these cases, and you would just assassinate the psoas, do this huge, shark bite incision and go in. And I'm amazed that people didn't have more, neurologic injury. But to me, Nuj, this was a great talk. I think the data is going to come. Like, we're doing some studies on what actually happens to the plexus when you extend the hip, because I do think that's, for me, honestly, the biggest thing about growing prone, not to belittle the lordosis, I really could care less, because if you do a good discectomy, you can get good lordosis. I think it's going to be, the plexus you're going to have less injury. Even though the plexus is fixated in the psoas, I think when you extend the hip, I do think it pulls it back, and I think we don't have any good data, but I think to me, that's the biggest thing about going prone.
Yeah. Yeah, I agree. I mean, I think there's two sides to it, and maybe you can elucidate some of this. One is pulling the psoas back and bringing the plexus back with it. The other, though, is that are you putting it on taut, on tension, by extending the thigh? So, there seems to be a little bit of a paradox with respect to it. But I think, studies are going to demonstrate, the data is going to come out. And if I'm correct, at least the data seems to be correct. I don't know from your personal experience, there is no increased issues with neuropraxia because of the prone position. And partly it's because of technique and where you are on the learning curve. So once, you have confidence with where you place the dilators and the retractors and you're aware of it like you teach, then you're going to avoid the neuropraxia. So being prone isn't reason to consider it as a contraindication, even a relative contraindication with respect to the plexus.
Must move on. Great topics,
Thank you.
great discussion. Thank you all.